Welcome back again. In this video, we are discussing about basic pharmacology related to Angina Pectoris. After watching this video, you will have a good idea about angina and its pharmacology. Today's contents. First, what is angina? Second, what are the types of angina? Third, classification of drugs. First part is what is angina. Let's have a look at what is angina pectoris and what is the basic pathophysiology behind this.
What is angina? Angina, also called as angina pectoris, is a central chest tightness or a heaviness which is due to myocardial ischemia caused by reduced blood flow to the heart muscles. Mostly it's caused by atheroma or arteriospasm. Rarely it can be caused by anemia, tachyarrhythmias or heart failure. In this diagram you can see what happens in atherosclerosis or atheroma. It reduces the blood flow to the heart because of the lipid deposit inside the blood vessels. In this diagram, it shows the narrowing of arteries due to arteriospasm. Because of all these reasons, when there is a mismatch between blood supply and metabolic demand, ischemic metabolites, including adenosine, stimulate the nerve endings and produces pain. That is what we call ischemic pain or angina. What are the risk factors for angina? Hyperlipidemia, obesity, smoking, diabetes mellitus, hypertension, and family history. These are the risk factors for angina.
Second part is types of angina. Let's have a look on what are the types of angina.
Types of angina. We classify angina by clinical presentation, so that mainly there are three forms: stable angina, unstable angina, vasospastic or variant angina. Stable angina, also called as effort angina, induced by effort and relieved by rest or minimal function. It is easily settled with medications. Unstable angina refers to angina of recent onset, less than 24 hours, or worsening of previously stable angina with symptoms frequently occurring at rest. It belongs to acute coronary syndrome. You know that there are three components in acute coronary syndrome: STEMI, non-STEMI and unstable angina. When it comes to vasospastic or variant angina, it is also called as Prinzmetal's angina. Refers to angina that occur without provocation, usually at rest. It is because of coronary artery spasms. It is more frequently can be seen in women. Characteristically, ST elevation can be seen in ECGs. Other than these, there are some other forms of angina, just like refractory angina and microvascular angina.
Let's move to the last part of our discussion, classification of drugs along with their mechanisms of action and adverse effects.
When it comes to the classification, only there are 3 drugs for angina, but you only need to remember only one because you already have learned calcium channel blockers and beta blockers from our previous videos. Let's have a look. Nitrates and nitrites. Examples are nitroglycerin, isorbit dinitrate or isosorbit mononitrate. And as usual, calcium channel blockers, verapamil and nifedipine. And beta blockers, metoprolol, atenolol and propanolol. Okay, this is your favorite part, classification mind map. First, nitrates and nitrites. The drugs are nitroglycerin, isosorbit dinitrate or mononitrate. We mainly want to remember nitroglycerin. It can be given sublingual for immediate relief. So what is the mechanism of nitroglycerin? It do vasodilation, so that because of venodilation it reduces venous return. Then because of the reduced venous return, the preload is reduced, so the oxygen demand for the heart reduces. The second part, arteriodilation. It increases perfusion because of the arteriodilation. How does it happen? Nitrates or nitrites release nitric oxide. Nitric oxide is a vasodilator. What are the uses of nitroglycerin? We can use it for all types of angina, stable, unstable or variant. What are the adverse effects? It can cause headache and postural hypertension because of the venodilation. The blood pressure drops, so it can cause postural hypertension, and it can cause reflexive increase in heart rate, and also mainly it can cause tolerance, so you need to change the dose with the time. Next, I will move to the other wing of our diagram, beta blockers, our favorite beta blockers. We first met beta blockers in antiarrhythmic drugs, metoprolol, atenolol, propanolol, all those. What do they do for angina? Mechanism. They reduces oxygen consumption because they block adrenogenic beta receptors. They compete with epinephrine or norepinephrine, so that heart rate reduces, contraction force reduces, blood pressure reduces. Finally, they reduce oxygen consumption. Uses. Usually we use beta blockers in effort angina combined with nitrates or calcium channel blockers. What are the adverse effects? It can cause sick sinus syndrome. What is this sick sinus syndrome? It is a group of abnormal heart rhythms caused by malfunctioning of the SA node, and it can cause AV blockade. And asthma. If we use non-selective beta blockers especially, it can cause asthma. Finally, we comes to CCBs, calcium channel blockers, verapamil, diltiazem and nifedipine. We discussed CCBs in our first video very widely. I hope you all can remember. So by now you should know what are the relevant groups of these calcium channel blockers. Can you tell me what is the class they belong? They all belongs to the group 1 selective L-type calcium channel blockers. More specifically, verapamil belongs to class 1C, phenylalkylamines, and diltiazem 1B benzodiazepines, and nifedipine 1A dihydropyridine. If you are someone who is new to our channel, I'll attach our website link here in this description box below. Then you can go and find all our videos and as well as these mind maps related. Let's move to the mechanism of CCBs in angina curing. So they decrease afterload. How do they do that? They act on vascular smooth muscle cells and they reduces contraction. So they dilate mainly only the arteries. Vasodilation, but only the arteries. CCB dilate. So they reduces the afterload. You know that if they dilate veins, the preload also will be reduced, but calcium channel blockers only dilate arteries. They inhibit heart contraction. The second one, inhibit heart contraction, reducing the power of contraction of heart muscle cells, and reduces heart rate by slowing down the conduction system. You know that conduction system also need calcium ions. So what are the uses of calcium channel blockers? We use it mainly for variant angina, nifedipine and diltiazem, along with nitrates. We can use that both for treatment and prevention. And what is the adverse effect? It increases reflexive heart rate.
Before finishing our discussion, let's have a look on effects of nitrates alone or in combination with beta blockers or calcium channel blockers.
Doctors usually prescribe nitrates along with beta blockers or CCBs. What is the reason behind that? This is the answer. This chart shows us what are the characteristics of nitrates alone or beta blockers, calcium channels blockers alone therapy with combined therapy. Finally, you will get to the conclusion that combined therapy is better. Just have a look.
It's the end of today's discussion. We hope you got a better idea about angina and its pharmacology. Thank you very much for watching our video till the end. Wish you a good health and stay safe.